About 1 of every 5 persons in America has an allergic disease. Allergy, in simple terms, is a specific, immunologically based response to substances that ordinarily do not adversely affect people. An allergic reaction may occur in response to something an individual inhales, ingests, has contact with, or is injected with. Symptoms range from mild to severe, even fatal, and may include upper respiratory, allergic rhinitis, and lower respiratory, asthma complaints. Individuals may suffer seasonal bouts of allergic symptoms, or may be ill perennially, depending on what in their environment causes their symptoms. The human immune response is based on a complex, interrelated system of cells and cell products. This system provides recognition and response to foreign substances, antigens, that contact the body or are ingested. Lymphocytes produce multiple classes of immunoglobulins that can be converted into specific antibodies targeting an antigen. After the immune response is initiated with the recognition of the antigen, the body's response is manifested by a growing list of cellular and intracellular mediators, complements, prostaglandins, leukotrienes, interleukins. Coombs and Gell classified the mechanisms of hypersensitivity into 4 classes. Type 1 hypersensitivity is mediated primarily by IgE, and is exemplified by the common allergic phenomena of allergic rhinitis, anaphylactic shock, urticaria, and asthma. Type 2 hypersensitivity is mediated by IgG, or IgM, directed toward cell-bound antigens. Hemolytic anemia in the newborn is an example. Type 3 hypersensitivity involves immune complex diseases, such as found in serum sickness. Type 4 reactions are characterized by delayed cellular-mediated immunity, such as contact dermatitis. We now recognize that most reactions represent a combination of types. Allergic individuals make abnormal amounts of antibodies, mostly of the IgE class, which are specific for the substances to which they are allergic. Patients who have a genetic tendency to make specific IgE may react to a number of substances, and cross-reacting antibodies to related substances may be present, such as to pollens from various grasses. In adults, most allergic reactions are to inhalant allergens, while food allergies are relatively rare. Allergic and certain non-allergic individuals may also be more sensitive to nonspecific irritants, such as strong odors, as well as to selected pharmacologic agents, such as methacholine and histamine. This discussion is limited to the diagnosis and treatment of inhalant allergies that affect the upper respiratory tract. Upper respiratory allergies will primarily be addressed here. Lower respiratory tract problems may occur as well, including asthma. It should be remembered also that allergies to ingested substances, including foods, may cause thickening of respiratory tract secretions and congestion. Similar reactions may also occur from skin contact and other allergic exposures. The mechanism of the allergic reaction is more complex than initially believed. The traditional explanation, including release of mediators from mast cells and basophils, secondary to linkages between IgE on the cell surface and the allergen, has expanded to include a long list of intercellular messengers, cells, and mediators, all of which appear to play a role in the development of the allergic reaction. Additionally, neurogenic factors may also be involved. The classic allergic reaction involves immediate hypersensitivity with symptoms resulting from the release of histamine and other cell mediators noted within minutes. Of the 4 types of hypersensitivity reactions originally described by Coombs and Gell, this is a type 1 hypersensitivity reaction. Late-phase reactions, mediated by basophils and mast cells through other mediators, such as prostaglandins and leukotrienes, can cause tissue inflammation that can persist for hours or days. Mild allergies are more incapacitating to professional voice users, singers, actors, teachers, salespersons, clergy, politicians, and others, than to others because of their effect on the mucosal cover layer of the vocal folds. For example, if a singer has a short period of annual allergy and is able to control the symptoms well with medications that do not produce disturbing side effects, empiric symptomatic medical treatment is reasonable. When more prolonged treatment is required, when medication side effects impair voice performance, or when relief is inadequate in the context of the voice user's increased demands, more extensive evaluation is required. The term allergic rhinitis, commonly referred to as hay fever or rose fever, describes an array of allergic symptoms involving the eyes, ears, nose, and throat. In effect, these terms are misnomers, since flowering plants do not have airborne pollen, and most fall allergic symptoms are brought on by weeds, such as ragweed, and not hay. Identical symptoms may occur in the summer and winter in response to exposures to common allergens, such as animal dander and dust mites. This fact holds special importance for patients who are commonly called on to travel often. Singers are particularly good examples. Allergies to dust and mold are aggravated commonly during rehearsals and performances in concert halls, especially older concert halls, because of the numerous curtains, stage fog and pyrotechnics, backstage trappings, and dressing room facilities that are rarely cleaned thoroughly. Since many singers travel extensively, location is important to bear in mind when attempting to elicit an allergic history, and when planning allergy treatment with regard to an upcoming performance schedule. Additionally, the history must include not only geographical location, but also details of recent working, living, and traveling environments. Politicians, consultants, sales representatives, and many others may encounter similar problems through travel, exposure to moldy warehouses, and other allergic encounters that should be clarified during the medical history. Allergic rhinitis is one of the most common etiologies in the development of chronic sinusitis. Patients with chronic sinusitis suffer from nasal congestion, postnasal drainage, pressure headaches, and olfactory disturbances. Chronic sinusitis can also exacerbate asthma. Undiagnosed or undertreated laryngopharyngeal reflux, or GERD, is often casually related to chronic sinusitis and asthma that is difficult to control. While the history may provide the best clues for the diagnosis of allergy, it can also be misleading. Nasal examination classically reveals hypertrophied, boggy nasal mucosa with a pale bluish color. Clear rhinorrhea is often noted, but thicker secretions can be present if there is an element of chronic sinusitis, or if there is relative dehydration. Allergic polyps are common in the nose and are usually found in the middle meatus, or involve the middle turbinates. Polyps related to allergy are usually multiple, pale, yellowish, and firm. Most findings of allergic rhinitis can be seen on routine anterior rhinoscopy. However, nasal endoscopy can be used for more detailed intranasal examination when necessary. Nasal examination performed before and after the application of topical mucosal decongestants, for example, phenylephrine and oxymetazolam, can help predict the patient's response to pharmacologic treatment. In addition to the findings on nasal examination, other head and neck signs of allergic rhinitis include conjunctival irritation and inflammation, periorbital ecchymosis, allergic shiners, serious otitis media, oral and pharyngeal drying, and lymphoid hypertrophy in Waldeyer's ring. On laryngeal examination, thick secretions with mucus stranding across the vocal folds, supraglottic edema, and vocal fold edema can be seen. Radiologic testing is usually not necessary in the primary evaluation of allergic rhinitis. When sinusitis is suspected, a non-enhanced CT scan is the best single study to evaluate the paranasal sinuses. Plain sinus X-rays may be used to screen children with acute sinusitis. As previously stated, allergy evaluation begins with a detailed history of the patient's symptoms and exposures. Appropriate testing can then be performed to look for demonstrated atopy. Skin prick testing can rapidly screen for reactions to a number of allergens. It is the quickest and least expensive means of confirming allergic sensitization. Patients must be off of most antihistamines for 5 days before skin testing can be performed. Tricyclic antidepressants, such as amitriptyline, have potent antihistamine activity and also interfere with allergy skin test results. Skin testing is generally contraindicated in patients on beta blocker drugs because of the increased risk of anaphylaxis if an adverse reaction to the skin testing occurs. Intradermal skin tests are the most sensitive way to look for signs of allergy. They may also provide a rapid answer, but they carry a higher risk of adverse reaction. Extremely rare fatalities have been associated with skin testing, which should be reserved for experienced practitioners who are prepared to treat the rare allergic reactions that occur. Radioallergosorbent (RAST) testing can measure antigen-specific IgE levels to multiple antigen classes from a single blood specimen. RAST testing is more expensive, but it is not altered by antihistamines. It is also not as sensitive as skin testing and usually requires at least a 1 to 2 day wait for results. It can be especially useful in those with dermatologic conditions that make skin testing impossible, or when patients cannot safely discontinue antihistamines or beta blockers. RAST testing has been used as a screening technique to confirm the diagnosis of allergy or as a basis for the development of immunotherapy, but there is inadequate evidence to justify its use as a substitute for conventional skin testing. When used on a regular basis, topical nasal steroid sprays may provide adequate control of seasonal or perennial symptoms. Steroids delivered topically by nasal sprays act locally on the tissues with which they make contact, and there is thought to be little systemic absorption or effect. There are multiple preparations that require only once or twice daily usage. Nasal and pharyngeal irritation is rare with these sprays, although epistaxis, nosebleeds, may limit use in some patients. Topical sodium cromolyn may also control allergic nasal airway disease with rare adverse effects, although in our experience it is less effective. A disadvantage of topical nasal medications is the fact that they do not control the ocular symptoms of seasonal and perennial rhinitis, which may accompany nasal complaints. Ocular symptoms may produce considerable discomfort in the atopic singer whose nasal symptoms have been relieved by topical therapy. Irritation of the eyes may cause increased eye blinking, which gives the false impression that the patient is nervous. Eye irritation may also cause slight blurring of vision that may make it difficult to read. Vasoconstrictor topical ocular preparations are also available over the counter and may also be used for transient relief. Most all of these preparations are contraindicated in users of soft contact lenses, and care should be taken to exclude other causes of ocular discomfort, particularly when that is the sole complaint. The treatment of ocular allergy was recently reviewed. When topical preparations do not adequately control allergic rhinitis, oral antihistamines may be necessary. All antihistamines can potentially cause drying, anticholinergic effect of the mucosal surfaces of the upper and lower airway, and most antihistamines also potentially cause some level of sedation. This can be a critical problem for people who speak or sing extensively, teachers, singers, clergy, and others, since even mild relative drying may cause major problems affecting both vocal quality and vocal stamina. Over the past few years, however, new drugs with minimal sedative and anticholinergic, drying side effects have become available. Since antihistamines do not directly address the problem of nasal congestion, decongestants are commonly added to the medical regimen. Decongestants are often combined with antihistamines to form preparations that both potentiate the mucosal drying effects and to take advantage of the stimulatory side effects of decongestants to counteract the sedation from the antihistamine. While the improved drying effects may control secretions more effectively, they may also cause voice disturbance by decreasing or thickening vocal fold lubrication. The newer, non-sedating antihistamines have also been combined with decongestants: fexofenadine, pseudoephedrine, Allegra D, and loratadine, pseudoephedrine, Claritin D. Decongestants can provide excellent control of allergic nasal congestion with no risk of central nervous system sedation, but they can also cause mild stimulatory side effects such as insomnia and tachycardia. At present, only pseudoephedrine is commonly available in the United States. Montelukast, a leukotriene antagonist, may also have decongestant activity. Combinations of this drug with antihistamines for the treatment of allergic rhinitis are currently under evaluation. The mucosal drying effects of both antihistamines and decongestants may be counteracted to some extent with mucolytic agents that liquefy mucus and increase the output of thin respiratory tract secretions. Guaifenesin is an excellent mucolytic expectorant. It is available as a single agent or combined with a decongestant. It is often necessary to experiment with several antihistamines, decongestants, or combinations before finding a suitable balance between therapeutic effect and side effects for any individual. The clinician should be familiar with many different medications and drug classes, both to minimize side effects and because patients may develop tolerance to antihistamines with long-term use, thus requiring changes in prescriptions. Drugs are usually taken initially in small doses for short trial periods to determine both the level of allergy control and the side effects. If a patient obtains consistent control of allergic symptoms and does not suffer from excessive drying, sedation, or hyperstimulation, these medications can be used safely for both short and long-term treatment. Acute symptoms of allergic rhinitis are usually quite responsive to systemic steroids. Intramuscular or oral steroids can rapidly reverse allergic inflammation and can also result in mild mucosal drying and mild CNS stimulation. Steroids can be used to treat a patient suffering an acute allergic attack, or to rapidly initiate medical treatment immediately preceding a difficult professional performance. In these instances, corticosteroids are usually administered as either a single intramuscular injection or a rapidly weaning course taken orally over 3 to 5 days. The use of long-term systemic steroids in the treatment of most patients with only allergic rhinitis is inappropriate due to the risk of serious side effects. Some patients are particularly sensitive to both the effects of their underlying allergy and to the medications prescribed to control their disorder. For this reason, specific allergen-directed treatment may be indicated. Appropriate testing is performed to look for demonstrated atopy. Once allergy is identified, avoidance measures provide a first step to limiting symptoms. It is well established that the less a patient is exposed to the allergens to which he or she is sensitized, the less difficulty he or she will have with unavoidable exposures. Environmental control may consist of measures such as providing air conditioning or dust control in the home environment. Alteration in clothing may also be helpful, as demonstrated by a singer who experienced difficulty in a new role that included a feather boa as part of the costume. After skin testing confirmed the presence of feather allergy, symptoms resolved with the substitution of a synthetic BOA. Immunotherapy injections may provide the best possible therapeutic modality for many patients, as they offer the opportunity for allergen-directed control of the allergic response. The mechanism by which allergen-directed immunotherapy works is not known. It has been proposed that IgG antibodies develop and block the IgE molecules at the receptor sites on immune response cells, but a variety of physiologic responses have been demonstrated. Immunotherapy is based on the pattern of allergy and demonstrated specific sensitivity as determined by allergy testing. Generally, the patient receives injections of slowly increasing concentrations of various allergens at weekly intervals. Immunotherapy is effective in a majority of appropriately selected patients who complete the full regimen. A variety of newer treatments designed to block some of the mediators involved in the allergic process are under evaluation. Monoclonal IgE is a recent addition to the physician's armamentarium, and its potential value remains to be clarified. Currently in the late phase of testing, and perhaps available by the time this is published, is a monoclonal antibody to IgE. Preliminary studies suggest this may be highly effective in patients with allergic disease. Issues of cost and safety remain to be resolved for this medication that must be given by injection. It may offer particular advantage to traveling patients who have a suboptimal response to medication and who have to travel frequently, thus making conventional immunotherapy impractical. Allergic disease is a common problem. It's important to remember that symptoms of allergy are generally chronic, but they may be acute with a new specific exposure. They may vary in severity and sometimes, but not always, have seasonal variation. Understanding the pathophysiology and immunology of allergy, as well as its diagnosis and treatment, is essential in providing comprehensive care. An appreciation for allergy and its implications is important for all clinicians.